Hello, everyone. My name is Zach Anderson. I'm a third year internal medicine resident, and today I'll be completing a presentation titled A Reflection on My Time in Medicine. And to be honest, the primary reason that I would like to discuss this topic today is that recently I read a book by Wes Ely called Every Deep Drawn Breath. And to be honest with you all, this book really changed my life. I'm incredibly optimistic about my future career, and I'd like to share some of the lessons that I've learned from this book, my experiences as a house officer and internal medicine resident, my reflection on my time in medicine. I'd like to share my desire to improve medical care overall, and I'd like to share with you my hopes for all of our future careers as physicians. So why am I doing this, and what do I hope you gain? Like I mentioned, I recently read the book Every Deep Drawn Breath, and it was truly life-changing for me. It reminded me of why I got into medicine, why I love caring for others, and why my career must be dedicated to improving the quality of our patient care. Through this lecture, I hope to share some of the wisdom I gained from this piece of literature and use evidence-based data to support the findings and practices I discovered in my reading. I hope to reinvigorate each of you to practice whole person healthcare and translate these lessons into real world actions. And really, above all, this book taught me that we must enact change today to avoid regret as we progress through our careers. So starting back at the beginning, and why am I including this? Because I truly believe that to know where we are today, you must know where we began. And so I'd like to start by focusing on where did the field of hospitalist medicine or the profession of hospitalist begin. In 1996, Dr. Robert Wachter and Dr. Lee Goldman coined the term hospitalist in their article, The Emerging Role of Hospitalists in the American Healthcare System. In 1998, they followed this landmark study with an analysis of how hospitalists affected the field of medicine. And this article provided support for hospitalist medicine as a vessel of quality, patient-centered medical care. In this article, they demonstrated a statistically significant reduced length of stay, decreased cost of hospitalization, and decreased readmission rate in those cared for by hospitalists. And since this time, the field has exploded. From 1998 to 2012, the number of hospitalists increased from 2,000 to 30,000. And in 2019, there were a total of 44,000 hospitalists in practice in the United States. Shifting gears a little bit and discussing critical care draws its roots from the early 1850s, when Florence Nightingale requested that the most seriously ill patients be placed closer to the nurse's station to ensure constant monitoring. Following this, Dr. Walter Dandy in the 1920s developed a 24-hour nursing unit for critically ill postoperative surgical patients at Johns Hopkins. In 1942, the Massachusetts General Hospital created a makeshift burn unit to care for burn patients after the infamous Coconut Grove nightclub fire, in which they cared for 39 critically ill individuals. In 1952, positive pressure ventilation was demonstrated as an effective means for ventilation during the Copenhagen polio epidemic. And this is the point in which critical care medicine really exploded. In the 1960s, ICUs became commonplace in U.S. hospitals, and this ushered in a new approach to critical care. Since this time, we've seen a rapid expansion of intensive care units across the United States, and in 2018, a total of 85,247 total ICU beds were available in the United States. So where did I begin? 5 years ago, I came into medicine as a bright-eyed and bushy-tailed individual. I was taught the intricacies of disease, but early in my training, I ignored how these diseases did not often occur in isolation, and really management of multiple chronic diseases with acute conditions would become the practice of medicine, which I fell in love with. I was asked to continue learning medicine while also practicing medicine, all while navigating an increasingly complex world of medicine. I describe this as the ultimate juggling act of residency. It's tough, it takes a lot of effort, and it really causes you at times to shift your focus from the person at the bedside to all of the other responsibilities that you have. I felt that I was tasked to prioritize efficiency and throughput. Everyone said you have to be faster at seeing patients, faster at writing notes, faster at communicating with other healthcare providers. And that's what I did. While completing all of the above steps that I thought would make me a great physician, I really feel that I forgot along the way the importance of exploring my patients' values, morals, and wishes, and how they are intimately intertwined with my ability to care for patients and truly restore their quality of life. So, where is medicine now? In 2022, there were a total of 33,356,853 admissions to U.S. hospitals. In 2021, U.S. healthcare spending reached $4.3 trillion for an average of $12,914 per person in the United States. Despite this, we see ever worsening outcomes. We have all the technology in the world, yet we still are spending so much money. And I really wonder, are we affecting the quality of lives of our patients? In the United States, the average person will have more than one ICU stay in their lifetime, and patients collectively spend 25 million days in US ICUs each year. As of 2022, 27.2% of all Americans, or 68 million individuals, carry greater than 2 chronic conditions. This is making medical care increasingly complex. And on average, despite all of these difficulties in care, ever increasing numbers of patients to care, ever increasing costs to care, we are asking our medical doctors to take on more and more patients, be faster. Currently, on average, a hospitalist cares for about 15 to 18 patients per shift. This equates to about 30 to 40 minutes maximum per patient in a 10-hour shift. And on average, a primary care physician cares for 20 patients a day for a total of 51 hours of care time per week. Even with this incredibly difficult load, greater than 25% of their time is spent completing non-clinical activities. So what do I see in medicine currently? I see that humanity is being replaced with efficiency. Numbers have become king. Our lab numbers, our vital signs, everything has taken precedence over the person in front of us. Quality metrics are now used to almost punish physicians rather than provide avenues for their improvement. Throughput values, decreased length of stay, decreased costs are all major driving factors in the United States healthcare system, and this blurs the importance of morbidity, mortality, and the genuine connection between the physician and the patient. I believe in modern medicine, we are really great at saving lives. Our technology is incredible, but it often comes at a large cost to the person whose life is saved. All of these issues, in my opinion, directly contribute to physician burnout, decreased patient satisfaction, and a general distrust for the modern doctor. And I think when you really think about it, that's where we're at today. So the next two topics that I'd like to introduce are syndromes which are caused by physicians. They're caused by our ability to save people's life, but we may be stealing quality of life from them by doing so. And these conditions are the post-hospital syndrome and the post-intensive care unit syndrome. Post-hospital syndrome is defined as a period of vulnerability during the first 30 days after a patient is discharged from the hospital. During this time, nearly 20% of patients will develop an acute medical problem that necessitates repeat hospitalization within 30 days post-hospital discharge. And post-intensive care syndrome, or PICS, is defined as the development of new or worsening cognitive function, psychiatric function, or physical function following critical illness. What I find incredibly interesting is that nearly one half or more of ICU survivors will suffer from some component of PICS. And at 3 months post ICU discharge, nearly 40% of patients will develop deficits similar to a moderate traumatic brain injury, and 26% will have deficits similar to mild dementia. This slide is a visual representation pulled from UpToDate representing PICS, or post-intensive care syndrome. And there's really two divisions of PICS: family PICS and survivor PICS. Family PICS is often denoted PICS-F. And as you look at the tables below these syndromes, you notice common themes: anxiety, PTSD, depression, grief. And for the patient specifically, you will see that it affects not only physical aspects of their life, but cognitive aspects as well as mental health. I'd now like to delve into some topics that I believe are playing a role in the development of post-hospital syndrome and post-ICU syndrome, or PICS. And Dr. Wes Ely in his book talks a lot about these topics, and he has dedicated his career to trying to find ways to minimize the impacts of each of these topics. We'll start with delirium, because I truly believe that this is one of the most important topics that we can talk about in acute care medicine today. Delirium changes people. And what do I mean by that? Well, to start, delirium comes in many forms: anxiety, agitation, hallucinations, overt confusion, and a new form of delirium, which I learned about through my research, is the silent or hypoactive delirium, which is often the most difficult form of delirium to identify. When we talk about delirium, we really need to talk about how many people are affected by this condition in the United States. It's mind-blowing to think that 10 to 40% of hospitalized patients and 50 to 80% of critically ill patients will develop acute delirium while hospitalized. And while many practitioners may view delirium as an acute episode that is transient, in my opinion, and I believe in Dr. Wes Ely's opinion, it is not a one-off disease process, and its effects are felt long after development. When you look at the data behind delirium, it has been determined to be an independent marker for mortality at 6 and 12 months. 1 month mortality affects about 14% of people, and at 6 months, 22% of people who develop acute delirium in the hospital setting will have passed. After 2 years, only 1/3 of patients who experience delirium will remain living independently in the community. And in those with underlying Alzheimer's disease, cognitive deterioration in the year after hospitalization progresses at nearly 2 times the rate compared with patients who do not develop delirium while hospitalized. I really truly believe that the key to treatment and management of delirium is prevention. Currently, there is no medication or direct therapy that is approved by the FDA for managing delirium. Risk factors for delirium include cognitive impairment, sleep deprivation, immobility, visual impairment, hearing impairment, and dehydration. Current standards of care focus on minimizing delirium risk factors as the cornerstone of delirium prevention. Here I've listed some interventions which I believe are key to prevent delirium, and these include frequent reorientation, including making sure the date and time are updated in a patient's room, cognitive stimulation, such as conversation, the use of puzzles, word searches, facilitation of physiologic sleep. Many patients in the hospital do not get enough sleep. Early mobilization, minimization of hearing and visual deficits by providing patients with their hearing aids and glasses, managing pain, preventing dehydration, and avoiding potentially harmful medications. Here I've included a table from UpToDate representing the common medications which are thought to be associated with causing or prolonging delirium or confusional states. And as you can see here, so many of the medications we use on a day-to-day basis can cause delirium. I've highlighted a few that I believe are the most common culprits, including opioids, fluoroquinolones, diphenhydramine or Benadryl, barbiturates, benzodiazepines such as Ativan, Versed, etc., baclofen, and cyclobenzaprine, as well as the phenothiazines or some of the early antipsychotics. This slide is something that I've included because I truly believe that in the current US medical system, we are overusing sedatives and antipsychotics. When you look at the data behind sedatives and antipsychotics, it's very limited in the setting of acute delirium. And benzodiazepine use can be particularly problematic in elderly individuals and frail patients. The Beers criteria recommend avoidance or very cautious use of benzodiazepines. I believe that benzodiazepines are significantly overprescribed, and the data supports that, especially for the use of delirium. Changes in mental status are the most common adverse drug reaction seen with benzodiazepine use, and this occurs in nearly 68.8% of patients. Despite this data, we still use these medications. And the use of midazolam or Versed in the ICU setting has been shown to lead to a higher risk of delirium and mortality, longer ICU stays, and decreased likelihood of discharge home. A single medication associated with so many impactful changes that we must minimize. Interestingly, when you look at the MINS 1 data, they demonstrated decreased rates of ICU delirium with the use of Precedex over Versed at 77 versus 54%. I think this data shows we should be favoring medications such as Precedex. In regard to antipsychotics, antipsychotic use in the ICU does not improve the number of days alive without delirium or coma. Despite this, we still use these medications in the treatment of delirium. The use of antipsychotics itself is actually associated with a higher relative risk of all-cause mortality and sudden cardiac death at baseline. No matter the patient population, no matter the person, it's associated with a higher relative risk of all-cause mortality. This isn't even limited to the first generation antipsychotics and includes olanzapine, quetiapine, and risperidone, some of the second generation antipsychotics that we have begun to use. The use of antipsychotics in those with dementia is directly associated with an increased risk of mortality, and multiple societies recommend avoiding use. As we all know, extrapyramidal symptoms are a side effect of antipsychotics, and their risk is highest with the use of first-generation antipsychotics. Despite this, Haldol is still used in the treatment of delirium. And then, per multiple societies, we should be avoiding the use of antipsychotics in the setting of withdrawal syndromes, including benzodiazepines as well as alcohol, in those with anticholinergic toxicity, and in patients with seizures. In his book, Dr. Wes Ely talks about the use of care diaries in the ICU to help individuals wade through a difficult hospitalization. He believes that these diaries allow individuals who develop delirium to review their hospital stay and hopefully overcome some of the impacts of delirium, such as hallucinations and false beliefs that they developed during their delirious state. Care diaries are essentially a way to help patients and their families understand what actually happened during a hospital stay, as these two groups often tell completely different narratives about their stays. These causes can be due to medication effects, sleep deprivation, fluid delirium, and acute illness itself. This causes a lot of distress and may serve as the spark for developing post hospital cognitive and psychiatric dysfunction. Care diaries themselves, they focus on providing succinct, understandable day-to-day accounts of care provided during a patient's hospitalization. It includes written and photographic accounts of care and may be written by family, staff, and any individual who is willing to provide a narrative account of a patient's hospitalization. And there have been quite a few studies to evaluate the benefits of ICU diaries. And this, through these analyses, they've been shown to reduce the incidence of depression, anxiety, and post-traumatic stress disorder in both patients and their relatives. On this slide, I've included an example of a care diary, and I truly believe that this may be one of the most impactful things that we can do. I won't go through reading these examples, but I do think that if you look up on Google examples of care diaries, you may see the benefit in them as well. They allow us to connect to our patients on a much deeper level. They also allow patients and their families to have a comprehensive understanding of the day-to-day actions which were performed during a hospitalization. I believe we should be using these in the care of our patients. Another topic that Dr. Ely discusses, and one that I find to be very true during my time in training, I believe keeping your patient mobile is a key aspect to the care of each patient. When you look at the data around mobility and hospitalizations, you'll find some pretty jarring information. Hospitalized adult patients spend nearly 83% of their time in bed while hospitalized, and only 12% of their time in bedside chairs. Immobility itself has been linked to the development of multiple complications of hospitalization: pressure ulcers, venous stasis, deep vein thrombosis, pulmonary embolism, hospital-acquired pneumonia, difficult weaning from the ventilator, and loss of muscle mass and strength. All of these things cause complications and add to the complexity of medical care for hospitalized patients. And immobility itself may result in deconditioning, decreased functional status, and increased length of stay. Nearly 30 to 60% of adults greater than 65 years old who are hospitalized lose some degree of functional independence during a hospital stay. And hospitalized older adults are 61 times more likely to develop a disability in the activities of daily living than those who are not hospitalized. And deconditioning is one of the most common reasons for delayed discharge from the hospital, the need for post-acute care, and early readmission. We have to act on these values. So what are our barriers to maintaining patient mobility in the hospital setting? These range from patient factors to nursing factors to staffing factors to institutional factors. And I lay out some of the things that I believe are the most important, and I believe the data supports this. The most common barriers to mobility cited by patients who are hospitalized include feelings of weakness, pain, fatigue, and the use of urinary catheters or other devices. Additionally, patients cite the lack of mobility assistive devices such as bedside commodes and walkers as another cause of decreased mobility, and staff would agree with this. In regard to nursing staff and other staff members, they see their high workloads as the most common barrier to mobility. Additional barriers include the use of IV piggyback medications, especially if continuous infusions, fear of falling, hospital based policies, lack of physician orders, and many more. So, how can we maintain our patient's mobility? I believe the most important factor in maintaining a patient's mobility is to accurately determine a patient's functional status. This should be a multidisciplinary effort with contributions from physicians, nursing staff, therapists, and family members. If you do not have a baseline on your patients, you cannot understand how far they have fallen from their baseline and how far you have to go to return them to their baseline. Once a true functional status is determined, an appropriate prescription of mobility activities should be initiated. In the most simplest terms, this can range from periodic shifts in position, such as rolling, sitting at the edge of the bed, hanging legs off the side of the bed, all the way up to periodic standing, walking in hallways, stretching. Our primary method for intervention relies on physical and occupational therapists in hospitalized patients. However, I believe this is unlikely ever to be enough. And we have to engage our patients and their family in activities as appropriate to make sure we're giving the best to our patients. My next topic I'd like to talk about is how religion and spirituality impact our patients' care. And when you look at America, Americans are highly religious. In a 2012 study, Williams et al. Found that 83% of patients reported a belief in God. 59% attend religious services at least once a month, and 73% say they try to carry their religious beliefs over into all other dealings of their life. In the hospital setting, nearly 40 to 80% of patients voice a desire to discuss religious or spiritual concerns during an acute illness. Despite this, only 32% of all patients say that some discussion of religion or spirituality occurred while they were hospitalized. And 50% of patients who desired a conversation about spirituality did not receive one. Among those who participated in discussions, most speak with a chaplain, and sadly, only 8% speak about these topics with a physician. I believe that engaging patients' spirituality and religious beliefs is one of the strongest things you can do to help them weather the storm of a hospital stay. And I believe that there are ways we can do this in a very non-confrontational, non-judgmental manner. I believe you should take cues from your patients. You should understand that religion does not equal spirituality. And just because someone doesn't have religious beliefs doesn't mean that they don't believe in a greater power or spirit which can help them traverse their stay. You should ask patients how you can support them spiritually or religiously. You should support patients within their own faith traditions. I believe it's very common in this country to impose our beliefs on other individuals, and I believe that this does not lead to any positive things when you're having to deal with an acute hospital stay and also trying to talk about this topic. You should avoid injecting your own beliefs unless you are specifically requested. This only can lead to animosity. If you don't feel comfortable discussing religious and spiritual beliefs, at minimum, we should be sharing encouraging words and thoughts with our patients. We should support their beliefs, even if we don't believe them ourselves. And despite my belief that physicians should be having these conversations with their patients, if you don't feel comfortable doing this on your own, chaplain services across the country are incredibly helpful. I believe nearly every patient should have the opportunity to speak to a chaplain if they wish. Another topic that I think is under discussed in medicine is just how important family is during a hospital stay. There have been multiple studies to show the impacts of isolating patients from their families, and I believe we all experienced this during the COVID-19 pandemic. Isolating patients from their family has been shown to increase the risk of medical error, emotional harm, cause inconsistencies in care, and lead to costly, unnecessary care. Family presence itself has positive effects on a patient's perception of pain, loneliness, and fear. When we weather the storm together, we're stronger. In hospitals where patient and family centered care is part of the organizational culture, have found that involving family in care leads to improved patient, family, and staff satisfaction ratings. It decreases anxiety for patients and families. It interestingly leads to a reduction in falls by 35% and injuries from falls by 62%. It leads to improved health outcomes. And despite some individuals believing this, involving family in patients' rooms, even during acute infection or a severe illness, does not increase the risk of development of further infection. So, what does patient and family centered care look like? The principles surrounding PFCC include recognizing the importance of family members' roles in individual patients' healthcare experiences. We must establish relationships with and supporting patients and families. By doing so, we can help patients discover how their own strengths and weaknesses influence their health and healthcare. And PFCC emphasizes that a patient's healthcare decisions should be contextualized in terms of a patient's broader life experiences. How do we accomplish this? I think it's really simple. Make time to listen to families. Share meaningful information with families in a fashion that may be comprehended and encourages collaboration. Get to know the family, get to know the patient, know their hobbies, their loves, their passions, what they're known for, what jobs they had. Knowing patients brings us back to the bedside. You should encourage families to be present during decision making. And if they're not, you should make a phone call to them and discuss your plan of action and plan of care with them. And in my opinion, I believe that families should be engaged in patient rounds. Just because families may not understand every word or lab that we present, letting them know that we are transparent and open in their family members' care provides trust and belief in the medical system. Another topic that I really believe that is so important to medicine is the idea of palliative care and hospice care. This conversation can be so difficult to traverse when you're dealing with an acute illness, and it is a difficult skill to obtain to have these conversations. But it's important and it's necessary, and we must be willing to do so. I included here a description of palliative care and hospice care as I believe that this description is one of the best I've ever read, and I believe it can help us provide information to our patients on what palliative and hospice care looks like in an accessible manner. Palliative care is like a friend who's there to help you through your illness with great care. It's not just for dying, it's for the living too, to help with symptoms and make your days feel new. Hospice care is like a warm, cozy bed for those in their last days to rest their heads. It's not about curing, it's about ease, making the end of life calm, like a gentle breeze. We have to be utilizing these aspects of care in the management of our patients. It's what we should do for our families, it's what we would do for our friends, and we should be doing it for each of our patients. So, looking back at this entire presentation and the problems I see in current medical care, I ask myself, how do we change these trends? And I really believe there is no one size fits all solution. But as physicians, we can shift the tides by changing the microcosms within which we find ourselves. I believe that each of us should take it as a mission in our careers to develop and implement care practices which focus on life after the hospital, even during an acute care event. Because that's what we want to provide our patients, the ability to return to their life, their quality of life after the hospital stay. We should emphasize whole person health care, caring for our patients' minds, bodies, and spirits, and their families. We should always try to find the person in the patient. Dr. Wes Ely, I believe, has done this so well in his career, and I aspire to be like him. We should shift the focus of treatments and interventions from an increase in the quality of life to increase in the quantity of life to improving the quality of life of our patients. Because quality of life is the most important thing. And then at an institutional level, we should begin petitioning administrative providers to place caps on patient loads and minimize non-clinical requirements. We're caring for too many patients. We're doing too much paperwork, and it's taking us away from the bedside, where the people we're caring for, the humans we're caring for, are. In his book, Dr. Wes Ely describes a care bundle which he has developed throughout his years of training to improve the outcomes of the patients he cares for in the ICU. This is now cited by the Society of Critical Care Medicine as a core aspect of ICU care in the United States. And there have been multiple spin-offs of this which are used to help liberate patients from their critical illness. This A2F ICU bundle, which has been developed, is proven to reduce time in the ICU, decrease morbidity, and decrease mortality. The A2F bundle consists of 6 components, A through F. A, assess, prevent, and manage pain. B, both spontaneous awakening trial and spontaneous breathing trial. In my experience, not every patient undergoes an SAT and SBT each day, but I truly believe that we must be doing this. It's in our patient benefit. It's in our patient's benefit. It shows less time on the ventilator, less time in the ICU. We should be very careful with our choice of analgesia and sedation. We should optimize pain management before sedating. And when sedating, we should use very light sedation protocols. And in my opinion, we should be avoiding benzodiazepines. D, delirium. Assess, prevent, and manage. This is a core aspect of the A2F ICU bundle, and it must be completed on each patient. Minimize pain, minimize sedative use, reorient your patient, open the blinds, let them know you're at their bedside and they're safe. Bring their family in. Have them provide blankets from home, pictures from home, play music that they love, talk to them about their hobbies. We must focus, the E, early mobility and exercise. As we've discussed here, it's shown to reduce complications. And finally, family engagement and empowerment. We have to be engaging our patients' families to truly make them better. Here's a visual representation of the A2F bundle, and if you would like more information on the A2F bundle, it's accessible on the Society of Critical Care Medicine under their ICU liberation protocols. With all the information that I've provided, and bridging off of Dr. Ely's A2F ICU bundle, I developed the A2F hospital bundle to help those around me provide better care to their patients. Again, it consists of really 6 components, A through F. The first being awake. Each day, at a reasonable time, you should awaken your patient. Maintaining a proper sleep-wake cycle reduces delirium. You should open the blinds at bedside and ensure a clock as well as the date are directly viewable from the bed. This helps ground patients. B, bedside. Before leaving any room, you should ensure that the bedside table is where the patient can reach it. Ask if there's anything they need. Do they need their cell phone charged? Do they want a glass of water? Do they need their reading glasses? Do they want a book, word search, puzzle? Get it for them. C, chair. We should be getting our patients up to the bedside chair as much as possible. As mentioned previously, nearly 83% of patients spend most of their time in the hospital in bed. This leads to deconditioning and increases their risk of rehospitalization and inability to return to their prior quality of life. D, diet and delirium. You should ensure that your patient is receiving adequate nutrition at all times. If they are not, get them nutritional supplements. And focus on delirium prevention. Orient the patient, open blinds, minimize sedation, analgesia, antipsychotics. Preserve sleep by limiting frequent disruptions if possible. Minimize overnight vitals, delay AM labs. Avoid early morning chest radiographs. I truly believe that patient sleep quality in the hospital is probably the most poor they'll ever experience in their life. There's data to support that the average hospitalized patient obtains less than 4 hours of sleep per night, and the average ICU patient even less than that. The effects of sleep deprivation have been proven time and time again. We have to minimize sleep deprivation. Whether that means shifting our schedules a little later to allow patients to sleep, or making sure that they have uninterrupted sleep overnight when stable, we should do it. E, early mobility and exercise. If you don't move it, you lose it. Keep your patients mobile when appropriate, and physical therapy is likely not enough. You have to engage the patient. You have to engage their family. It may be the difference in them returning to their quality of life. And then F, family engagement and empowerment. You should engage your patients as much as possible. Encourage them to bring pictures, blankets from home, spend the night, and prevent daytime napping to manage delirium. Dr. Ely himself actually states that if his family were to be hospitalized, he would spend as much time possible with his family who's hospitalized, even if that meant staying greater than 24 hours. And last, I'll leave you with my closing thoughts on this topic. I believe as physicians, we should listen first. Be the person who stands for their patient. Be their voice when they can't speak. Spend time discovering how to be most effective when caring for each patient. Assess their values, wishes, beliefs. Assess what their quality of life was before the hospital and where they would like to return. Be effective. It's okay to form connections and show emotion. In my experience, many practitioners separate themselves to divide themselves from the pain that can come from not being able to save someone or not being able to make their life better. But those genuine connections are what make this profession so unique. Advocate for care that puts the patient first and focuses on life beyond the hospital. There are so many procedures, technological advances that allow us to do more testing, do more procedures on patients, but that doesn't always mean it's going to change their outcome. That's too much of a cost, in my opinion. Assess your patient's quality of life and do all you can to preserve this. It's the most important thing. And lastly, mortality is not the only important measure. The arc of illness does not end when a patient leaves the hospital, and it instead extends into their home, their family, and their community. Their quality of life is what matters. Yes, we want to prevent mortality, but not at the cost of quality of life. Here are my references for this topic. Feel free to access them at any point. And lastly, I leave you with the concept of whole person healthcare. Mind, body, spirit. They're inseparable, and we must be willing to care for each of our patients in each of these aspects.